Yes, please, can you hear me? Okay, good. I hope the network is better now. When it is time for us to catch the concept well, because this, I don't want you to miss this topic. Okay, it's really going to help you guys. Yeah, the network is distracting, but it's better now. I don't think it's going to do that again. Okay, yeah, right. Okay, so let's start. I don't want to waste time. Do, do. Okay, good. So, cardiovascular emergencies. Cardiovascular emergencies. Okay, I think this should be better. Let me monitor from this side. Let me monitor from this side. Okay, are we good to go? Okay. Good. So, like I was saying, cardiovascular emergency. Okay. So we've done the objectives. I'm starting all over so that when you watch it, because the other video I'll delete it. So cardiovascular emergency. Okay. So we've done the objectives. We know the meaning of cardiovascular emergency. That any condition that threatens your circulatory system, threatens oxygen delivery, threatens cardiac function, limb viability, or life. That is what cardiovascular emergency. Okay. Now, and we've looked at the medical conditions that we can classify them as what cardiovascular emergencies. We have the acute coronary syndrome, the cardiac arrest, the life-threatening dystrachnias, aortic dissection, pulmonary embolism, the acute heart failure and pulmonary edema, cardiac tamponade, hypertensive emergencies, and acute arterial occlusions. Uh, the next is the approach, the nursing approach. Anytime you get any patient that either the ambulance or they walked or the family members brought them, whether they are conscious or unconscious, this is the approach you should go. Okay, the ABCD approach. So assess their airway to check for patencies. Assess, look for altered consciousness or inability to protect the airway. Prepare the suction and advanced airway equipment, the ET tube, the LMAs, okay, the vents, okay, and all those oropharyngeal and nasopharyngeal airways. Okay, then the breathing, you are looking at the respiratory rate, okay, the breath sounds of the patient, the oxygen saturations, the cyanosis. We are still in the assessment phase. We are assessing the patient to gather our data, okay, the pulmonary crackles and use of accessory muscles. And you should be able to what? Gather informations, okay, so that, and you should be quick. This thing I'm saying, when it happens in real life, I'm not going to talk like slowly like this. It's going to be quick. Okay, this is a quick assessment. So you can connect the monitors and it will do all your vitals, check everything for you. You check there is a pulse, you check for GCS, AFPU, alert, and all those stuffs. Okay. So with the breathing aspect, if there is any breathing issues, let's say hypoxemia, respiratory distress, or shock, give your oxygen. But if there is none, oxygen is not automatic to give. Okay. Yes, especially when saturation is adequate. Don't rush to give a patient oxygen. Okay, right. Circulation. So we move to the circulatory system. What are the things you're going to gather there? Your heart rate, your rhythm, your blood pressure, your pulses, your skin color, temperature, and moisture, your capillary refill, the level of consciousness of the patient, the urine output, okay, then temperature, add temperature to it. Temperature is under what? Circulatory system. So add it. Quickly, what are the things the nurse will do? The nurse should establish the IV lines, okay, a large ball, 20 gauge, 18 gauge, 16 gauge. Okay, yes, you do quickly. What if the patients, we cannot get IV? Can you treat a cardiac or cardiovascular emergency without IV line? No, it's not possible. So what do you have to do? If you can't get peripheral, you can do intraosseous. Intraosseous. Okay. When are we going to? This is an emergency. I must act in a space of 10 to 20 minutes. I must act because patient is crashing. When are we going to do ultrasound IV to even come and identify an artery and a vein? It's a long time. So intraosseous IV, quick, and nurses can do that. Okay, right. So you, after you pass your IV for the circulation, then you obtain your blood samples. You place the patient on continuous cardiac monitoring. When you go to message, this one they call it telemetry. Telemetry, okay, yes, and prepare emergency equipment. Emergency equipment for what? Breathing, circulation. So we have what? The rapid infusion pumps, okay, the bags, the pressure bag to push fluid down, and all those ones. Okay, these are the emergency equipment. Good. Disability. So with that disability, you are looking for the the brain functions. Okay, the brain functions. So I've told you that anytime you get to disability, you are looking at your AFPU. This is an emergency. Your AFPU or your GCS. GCS will take time, but AFPU quick. You are gone. You know your level of consciousness? Is there any confusion or new confusion? Is the patient passing out or has already passed out or alert? Okay. Is there any focal or neurological deficit? Cannot raise the hand. There is facial drooping. Patient cannot, pupils are fixed. They cannot even follow your arms and all those things. So you, after with this assessment, you will know all these what disabilities quick. So a cardiovascular emergency can reduce what cerebral perfusion. Okay, so that is why you need to do what your disability. Good. Then exposure. Exposure is about the body. Sometimes exposure can what affect cardiovascular system. Okay, exposure. Ah, so you do assessment from head to toe. You check for the head. Is there any injuries, crash injuries? Is there any cut and all those stuffs? You check the face. Is everything fine? You come to the neck. What are the jugular veins saying? Is it distended or flat? Okay. You check for edema of the pedals. So you do head to toe unequal pulses, okay, here or the groin, okay, or the pedal pulses, you check. Then you check for leg swelling, signs of any bleeding, you check. Then recent surgical or catheter access sites, okay. Yes, so patient has come with what? A PIC line, okay. You check for the site. Patient has come with what? A hemodialysis line, you check for the site. Patient has come with a port, implanted port. You check if everything is fine. So this is what exposure. You have checked everything. Okay. And the abdominal region exposure. Is the patient having any PEG tube? Is the patient having any urostomy? Is the patient having any colostomy? Okay. Patient in the respiratory unit, are they having any chest tube? So all these things you check, then you note them down quick. Okay. Now most patients with what cardiovascular system come to the hospital with what chest pain, chest issues. Yes. When I go to your chest, I'll find two organs: the heart and what the lungs. So patient complains of chest pain. What should come to your mind is what the PQRST. A lot of people make the O silent, but if you want to be OPQRST, ABCDEFGHIJKLMNOPQRST. If you know this, you are gone. The O is always the onset. So when did they start? What was the patient doing? Okay, yes. So the onset. Then the P is what the provoking, what provokes the pain. Somebody will say that, yes, I'm having chest pain. When I stand up and I start walking, when I run, then I'm having, so these are the palliative issues. Okay. When I'm walking, then the pain will be high. But when I sit down or when I sleep, the pain goes. So the things that intensifies the pain, those activities, some will say that whether I stand, whether I sleep, whether whatever I do, the pain, the way it is rather becoming, it is rather increasing. Yes. So you do that. Then the Q is the quality of the pain. So you describe, in your nurses know you should describe quality of pain. Anytime patient complains of pain, and you can use this algorithm for every pain management in this world. Any patient you get, the Q is the quality. Some will say, I have dull pain, I have sharp pain, I have numb pains, I have aching pain. Those who come with headache, I have ache. Okay, yes, I have tearing pains and all those stuffs. Okay, yeah. So you should be able to, please, the font size, is it okay for you? If it's not okay, good. Right. Then the R is the radiation or the region. Which region Which region is the pain? Women will complain of what? Abdominal pain. They are having heart attack, oh, but they will come with abdominal pain and tell you that the pain is radiating to the back. So you should know when the pain is starting, the location of the pain, and ask, is it radiating to another location? So we call it the region and the radiation. So the region, mostly some cardiovascular emergencies, chest pain, arm pain, jaw pain, back pain, shoulder pain. Yes. So that is what they will do. Then the S is the severity. So the 0 is to 10. Okay, where 0 means no pain, 5 means moderate. Okay, then 10 means severe. So you do all these ones. Okay, then the time, when did it begin? Is it constant or intermittent? Okay, so once you gather all these, you've assessed for the pain, then you ask the patient, are you dyspneic? Okay, or you assess, is the patient dyspneic? Is the patient diaphoretic? Is he having nausea or vomiting? Okay. Do you feel like throwing up? You have palpitation, syncope? Are you using any cocaine or methamphetamines? Are you having any cardiovascular history? Are you diabetic, hypertensive, smoking, or hyperlipidemia? Are you having any erectile dysfunction or using any erectile dysfunction medications? Are you using any anticoagulant, heparin, all these aspirin, all these warfarin? Are they using it in the house? Are they taking clopidogrel? Are they taking apizaban? So all these ones you check. Okay, yes. Then recent surgery. Have they done any surgery? Recent abdominal surgery, shoulder, hip surgeries, and all those ones. You ask them. Okay, immobilization. Are they people who walk or not? Yesterday we learned it. Okay. Have you traveled recently for a long distance? Let's say you travel from UK to what? US. Over 9 hours flight. You are sitting down at one place for 9 hours. Signs of what? Deep vein thrombosis or clot formation, pulmonary embolism, all those ones. So people travel from the eastern part of Ghana to the north. Okay, people will travel from UK, the north side of UK, to London. So all these ones will help you to what? To know. Oh, to know. Right. So what are the immediate investigation? Now you've collected your data. You know the situation of the patient. You know the background. Where do you start your treatment from? Start treatment from the you have your IV lines already in. Okay, yes. So you start your treatment from the 12 lead EKG sharp, the electrical system. We are dealing with cardiovascular system. Okay, cardiovascular system. So when you go to the cardiovascular system, we have the muscles, we have the bones of the chest, the muscles of the heart, we have the blood vessels, the BVs, we have the electrical system. So all these divisions, you are going to check it. Okay, the muscles, what do you check? You check for what? Your chest X-ray. Okay, to know the size of the heart and the bones. Is any of the bones intact? Is the trachea intact? Airway? Is there any pulmonary system defect or disorder? Is there any pneumothorax or whatever? You check all those ones. Okay, then you go to the bones. The chest X-ray will help. Okay, the blood vessels. So you can do your CT scan, the CT angio, CTA, then CT perfusion. You know these ones. Okay, these three things. So when we say CT scan, no, not only one test. You take the patient to CT. A patient has come with stroke. Okay, CT, CTA, CT perfusion. So you take the patient to the city, they will do all these three things before the patient comes out. Okay. Electrical system, how do you do 12 lead EKG? It should be done within 10 minutes if you suspect any acute coronary syndrome or MI, you suspect angina, you suspect anything, 12 lead EKG. Remember, okay. So remember you set up your IV. So you do your blood draws. Your blood draws, you are checking for what? The troponin. So we have the troponin O and troponin 1 hour, the 0 minute and the 60 minutes. So in my hospital like this, the nurse's computer on your screen, if you are managing a cardiac patient and there is a troponin order, the machine will be doing the counting for you. So when it passed 1 hour, the color of the timer will change to red, very big red, that you will see that, oh. So there is no way you can go and lie that you did not see, you forgot that I needed to do a second troponin blood draws. Yes. So you do your troponin, CBC, electrolyte, the glucose, every emergency glucose, renal function test, coagulation cascade. You do your chest X-ray. We have already mentioned it. Never allow diagnostic testing to delay emergency treatment. Okay, let's move on. So let's take the conditions one by one. Let's take the conditions one by one. The conditions one by one. So I was saying that the acute coronary syndrome, the ACS, anytime we mention ACS, you think about these conditions. Is the lumen of the coronary arteries totally blocked, or partially, okay, blocked? Okay, yes. So if it is totally blocked, we are looking at what? The MIs, the unstable MI. Okay, okay, yes. Then if it is partially blocked, we are looking at the what? Anginas. Angina. Because we are dealing with emergency conditions, we will consider the unstable angina. Unstable angina. Then partially, we have what we call the non-STEMI, the end STEMI. Okay, the end STEMI. So these are the things we are looking at. If you look at it this way, you know how to treat any condition that comes your way. Okay, totally block, unstable, or STEMI. We call it the STEMI. Okay, the STEMI, the STEMI, and the end STEMI, and the unstable angina. Okay, unstable angina. Partially blocked. How will you know that this is angina and this is STEMI or end STEMI? Angina, the troponin is always stable, almost like 99% stable. Okay, but the end STEMI has what? The troponin will be shooting up. The troponin will be shooting up. So these are the things you should also know. Then if you look at the EKG too, the STEMI guys will have what? Elevated ST segment. Okay, ST segment elevated. Okay, then the end STEMI and the angina guys, if you draw the zero line, you realize that the ST segment is below it. That is it. Okay, now, so all these pictures, I've added it for you to know. And you should know, I always say that females, older people, yes, somebody can come to the hospital with diarrhea, with nausea and vomiting. but it is a heart attack sign. Okay, so not everybody will walk to the patient hospital with chest pain. So you should take note of that. Okay, so the coronary artery can be what blocked by a plague, a platelet that will be aggregating over there. Okay, a thrombus, all these ones can block it. So you should take note. Then I also explained to you the stable and the unstable and the NSTEMI and the STEMIs. Okay, yes. So these are all conditions that are classified as what? Emergencies. The NSTEMI will give you what? Elevated troponin. The unstable angina, the troponin is mostly stable. Without myocardial necrosis troponin pattern. So take note. Okay. And the STEMI, troponin will shoot. And the ST elevation too is there. Okay. How will this patient present? Majority, about 80% or 90% of these patients will come with what? Chest pressure. Chest, something is squeezing, they feel that squeezing sensation in their chest, heaviness inside their chest, or tightness. An elephant is sitting on my chest. There is a pain. Some people too will come with pain, severe chest pain, and they will describe the pain is radiating to their back, shoulder. So if you divide the chest like this, okay, this is the anterior, that's the posterior, and up. Okay, so chest pain radiating to the back, radiating to the shoulder, radiating to the neck. Okay, yes. So these are the things you should know. Dyspnea, and they are diaphoretic. There is also nausea and vomiting. Okay, then feeling of an impending doom. They feel they are going to die. So these are the let's look at women. Oh, sorry. Let's look at women. So women mostly come with what? Women, older adults, and patients with diabetes. So NCLEX will test you that a woman 48 years old, a woman 72 years old woman, 72 years old woman with diabetes type 2, type 1. This is so you should know that the signs and symptoms they are going to give you, if you are not careful and your physiology is not good, you might think that, oh, this is just a normal patient. They can give you indigestion, weakness, dyspnea, and what? Minimal or no chest pain. This is a heart attack problem. Okay, a heart attack problem. Yes. So women can come with no chest pain or minimal chest pain. So you do your quick assessment, activate the STEMI code. Okay, people with the rapid response, they will come and help you. Okay, then your 12 lead EKG within 10 minutes, connect the patient to constant cardiac monitoring. Okay, the 5 leads. Okay, yes. So the 5 leads, you do that, smoke over fire, sky over green, chocolate in my heart. You are done. Then you you establish your IV line, draw your blood, send to the lab. Okay. You give chewable aspirin. We call it baby aspirin. Baby aspirin. Baby aspirin. Okay. Unless contraindicated in the patient. Unless contraindicated in the patient. You give nitroglycerin when appropriate. When appropriate. Okay. Yes. When appropriate. Yes. A patient who is taking all these impotence, okay, or sexual dysfunction medication like sildenafil, or those males, Don't give this. It will cause what? Significant hypotension in the patient. Okay. So you should ask the patient, are you taking any medication home? Okay, at home or what? Provide oxygen when clinically indicated. Clinically indicated means patient, you are seeing signs of what? Respiratory failure. The saturation is dropping. Patient is having respiratory distress. Okay, so you give your oxygen, then administer additional antiplatelet, anticoagulant, analgesic prescribed. Okay, aspirin, give it. Give aspirin. Give aspirin. Then you prepare for what? Urgent reperfusion. So the CAT scan, or the CAT lab. Okay. Yes, you prepare for CAT lab. We are taking the patient to the CAT lab to take away the clot, to take away the blockade, to repair the blood vessel that has ruptured. Okay, so whatever is causing the trouble in the heart. So let's take note of that. Now, this used to be a big acronym in the world that everybody, those days that when people were writing in class, Mona, some will say Onam, some will say no. Nowadays, all these acronyms, yes, it's there just to tell you what to do, but it is no more robotic. So don't go and do chew and pour. It is no more robotic. Okay. Yes. We give per assessment. The only thing we can confidently say is the aspirin that you give the baby aspirin. So aspirin remains an important intervention unless it is contraindicated. Otherwise, don't skip it. But for the rest, you assess before you give. Morphine is not again the first line of treatment. It's not. Before it used to be the first line. Now research and evidences have come. So don't go and jump and give morphine. The doctors will not even prescribe it for you to even see it in the treatment card to give. Okay. Oxygen. You give oxygen for hypoxemia or respiratory distress. COPD patient has come with cardiovascular emergency. What is the highest saturation you are focusing on? Yes, tell me your answer. COPD patient has come with what? Cardiovascular emergency. Saturation is 82%. What is your target saturation for this COPD patient? Yes, shoot. Somebody says 82, 88 over 92. Yes. 92, 87. Yes. So we are looking at 88 to 92. Yes. Yes. I'll find a day and explain the physiology of COPD. After that day, you will love COPD management. Okay. Yes. Perfect. So let's continue when we have time today, after when we finish early. But this is a short slide. Okay, we should have even been done by now, if not the network issues. Okay, nitroglycerin must be screened for contraindications. Okay, yes. So all this aspirin is the most important now, but the rest assess before you give. Okay, don't go and throw oxygen on a patient who does not need it. Don't go and give COPD patients with saturation 100% and think you are doing the patient good. You will knock off the hypoxic drive and the patient will die. They will sleep and die on you. Okay, yes. When you go, you are giving COPD patient oxygen and the saturation is 97, 99, and they are feeling drowsy, they are sleeping. You talk to them, they are not minding you. You think you are doing good. They will die on you. So, so nitroglycerin is a vasodilator. It's a vasodilator. Okay. Yes. So you check your blood pressures, you check for erectile dysfunction medication use, you check for suspected right ventricular infarctions, you check for severe aortic stenosis, you check for other contraindications before you give. Avoid nitrates, avoid GCN, okay, GCN after you've taken this medication. So when you take sildenafil, it is 24 hours. This time, these times, never forget it in your life. Never, because Nclex, it comes. Sildenafil is what? 24 hours. Tadalafil is 48. And Avanafil is what? So me, what I understand is I don't have to chew this. All I have to do is what? AST. AST. So I go to work at 12 hours. Okay, that is the Avanafil. When I pick overtime, it means I've done 2 shifts. That is 24. Sildenafil. Okay. Let me do let me do another 2 days on top. 24, 24, 48. I've done Tadanafil. I'm done. If you know this acronym, this one, nobody, you will not see it in any book. This statement I just made, you will not see it in any book. This trick I've given to you, you will not see it any book on this earth. AST, 12, 24. So Avanafil is 12 hours. So Sildenafil is 24 hours. So you ask the patient. The patient said that, yes, I have erectile dysfunction. The urologist is giving me medications. Which medication do you take? I take what? Sildenafil. Sildenafil, what is the first letter of sildenafil? S. Okay, then I go back to my acronym, AST. Okay, I work 12 hours times 2 is 24. If I want to multiply this times 2, so it's a game of times 2 of 12s. Okay, so sildenafil is 24 hours. Oh, what time did you take your sildenafil? I took my sildenafil at 7 a.m. or p.m. yesterday night. And it is what? The patient came at 6 a.m. Do I have to give glycerin, nitroglycerin? No, because it's still less than 24 hours. Okay, still less than 24 hours. Yes. So if you miss this class today, I mean, I don't know what I can do for you again in this life. Okay. Yes. Sometimes I feel worried when people come to my DM. Please, I don't understand this. But when you do class 2, they are nowhere to be found. Okay. So we are continuing. How do we reperfuse this patient? This is the heart, and this is the coronary arteries. The coronary arteries are blocked. We have to go and remove the clot so that the patient can what? Start the heart muscles will not die, blood will start flowing in and out. Okay, we call it the percutaneous coronary intervention. Percutaneous coronary intervention, PCI. PCI. So you hear them saying what? Activate the cath lab, activate the cath lab, activate the cath lab. Yes. So the cardiologist will come and assess the patient. Then the nurses and the other staff in the cath lab, they will prepare the equipment. Patient to the cath lab. Okay. They take the patient to the cath lab. The cath lab, how can they know that something is going on in your heart? They have something, another examination they will do. I'll come back to this. They have another examination they will do. We first scan your chest. You see that ultrasound. The pregnant women, when they are pregnant, they go to clinic and they use ultrasound on their belly. There's another ultrasound with a probe that we use it on your chest. Okay, yes, we use it on your chest. We use it on your chest. Okay, yes. So they will do that one for you. It's called echocardiography. Cardiography. Okay. When I do normal echo scan on your chest, what am I looking at? I am looking at the heart. So I divide the heart into four. They will first see here, then they look at the valve here. Is it working well? Then they look here. Then they look at the pulmonary artery, the valve there. Then they come to what? The ventricles. Look here. Either way you want to go, fine, that is you. You are holding the probe. Then you look at the left atrium, the valves here, then the aorta, the valve. Okay. Now they come and assess what? The blood here. Oh, estimated blood that came here, 1,000 mils. Okay. When the heart pumped, how much was it able to pump out? 200 mils. So what is your ejection fraction? Ejection fraction. So the echo will help you to know the ejection fraction. What is the normal ejection fraction of a human being? Yeah, send me answers. Pa, 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 pa. Every human being. Ejection fraction. Good evening, Everest. Good evening. Yes, normal ejection fraction. Shoot your answers. Sharp. Normal ejection fraction. We are treating the patient too. So you should take take control. Yes, we have done chest scan. Okay. 55, 60, above, some would say 40, like, yes, good. So below 40 is a big trouble, okay? Below trouble. We can't give your ventricles, let's say 5,000 mils, and the ventricle is only pumping what? 1,000 mils for systemic circulation. Okay, what is it keeping the 4,000 mils for? This is a sign of what? Ventricular failure or heart failure. You begin to have this pedal edemas and all those stuffs. Okay. When we do the normal echo and the echo, we don't get clear values, we don't get clear understanding of it. They will do what? An invasive, this is a non-invasive procedure on your chest. But when we do the echo and the echo, we don't get clear values, we don't get clear understanding of it. We still need the echo. Okay, we still need the echo. So they will do what we call the transosophageal. So they will pass a very long rope, those who work in big theaters, long rope, let me call it rope, through your mouth. So they will pass it through your mouth. If this is your mouth and your esophagus. Okay, they pass it through your mouth to your esophagus. And this echo has a torchlight here. They have a scanner here. So it will scan, in your esophagus down. Okay. So this is your heart. They will view everything. So we call it the transosophageal echocardiography. And that one works far better than this. Okay. Yes. So they will do. Okay. Now you have seen that there is a big clot sitting somewhere in your coronary arteries, or any of the valves is not working well. So you are getting regurgitations. Your ventricles have become big, they are not working. So I mean, all these stuffs. So what do? We have to what? Go in and do PCI. When we do PCI, this is the patient. We look at what locations for arteries. So it's either your hand, there is an artery here, the radial, or they'll go here, the groins, tap into what? The femoral arteries, straight to your heart. Okay, and go and repair and remove that clot. If there is a dissection, they will go and solve that one. Okay, yes. So you do this one. There is a clot. We need to give up fibrinolytic. Fibrinolytic. If you get if you get injury, and you are bleeding, the blood vessel here is cut open, so blood is coming out. Should we allow the blood to come out? No. So the platelet will start coming together. It's a natural phenomenon. They come together. We call it what? Platelet aggregation. Can it remain like this? No. Okay. If it remains like this, some pressure, blood pressure will come and remove it from there. Okay. So how do we keep this thing here so that the bleeding will not continue going on? We put a certain cloth. You see, mothers, when we are sleeping, they will cover us. Sometimes we sleep, we forget to cover ourselves. They will come and cover us with a cloth inside the blood vessel. When the platelets are sleeping and they don't cover themselves, the the fibrin factors, we call it the fibrinogen, fibrinogen, the fibrin, okay, the fibrin mesh, they will come and cover it. Yes. So over here, I have a fibrin, I have a platelet. Okay, I have a platelet. So if I take away the fibrin, it is very easy to remove the platelet. So what do I do? If patient comes with clotting issues, and we don't want the clotting because once the platelets start aggregating, fibrin will cover it, and you get proper clot. Okay, yes. So what do we do? Let us get a medication that will remove the fibrin, and even if there is clot, eh, this one will not get that strength to form forever. So we call it the fibrinolysis, breaking of fibrin. And one typical example is heparin. That is why we do the heparin drip. The heparin drip. Heparin drip. Okay. Consider for eligible STEMI patients. Before you give heparin, you should know your clotting time. Clotting time. Heparin works on the intrinsic factors, intrinsic pathway. Okay. So, in the intrinsic pathway, if I want to know this is the pathway, the extrinsic and the intrinsic, they come and join together to form factor 10. XA, factor 10. Okay, yes. And the factor 10 will form the common pathway. Here is heparin's work. Intrinsic, they work on the intrinsic pathway, and warfarin works on what? The extrinsic pathway. So if I want to check the time that will clot in the extrinsic pathway, I have to use what? INR. If heparin uses the intrinsic and I want to check the time the blood will clot in the intrinsic pathway, I have to use PT or what? APTT. So I want to give heparin on the intrinsic. Which laboratory investigation will I have to do? Do I have to go and do laboratory investigation for extrinsic? No, I have to do for laboratory investigation for intrinsic. That is what PT and INR. That is it. Okay, PT and INR. Good. That is it. So you fibrinolytics are not used for STEMI or unstable angina. Okay, yes. So these are the things you should know. You screen carefully for bleeding risk and contraindications before you set up your IV stuffs. Okay, let me make it big. Yeah. Okay. Now let's look at the next condition: aortic dissection. Aortic dissection. Okay, aortic dissection. Yes. Aortic. Oh, sorry. Aortic dissection. This aorta. This aorta, see how big it is. Okay, this aorta is coming straight from the left ventricle. Okay, and they will take their blood, pass through the aortic valve, enter into the aortic ascending aorta. Okay, then they go descending. Whilst Immediately they start descending here. They start this journey down. They are coming all the way to your abdomen, a little below the umbilicus. If this is your umbilicus, okay, they are coming here all the way here. Then they divide into two. One will pass here, one will pass there. Okay, like this. So one will go to the right leg, one will go to left leg. Anywhere, like a river flowing from the north to the south, every town it gets to has its name by the same river. Okay, so in the descending aorta, eh, we have the torso. The torso. So this is the chest area, and this is the abdominal aorta. Okay, or the pulmonary aorta, pulmonary chest, pulmonary aorta. Aortic dissection can occur here and can occur here in the abdomen. Before aorta will tear, 98%, the aorta must become big. Okay, can become big. Look at a blister. Okay, when you get burns, the skin will form blisters. So they will form blister. Okay, they will form blister. But remember, the aorta has layers. Every blood vessel has layer. We have the muscle side, the media, the inner layer, inner lining. We call it the intima. The outer lining, we call it what? The external. And the inner lining, the muscle, is called the what? The media. Okay. When this side, the external and the muscle, they bulge out like this. See this side. This is called aneurysm. It is swelling, aneurysm. But as time goes on, can this inner lining alone stand this pressure, blood pressure? Maybe sometimes the patient even has high blood pressure. Okay. This inner lining will tear. When it tears, blood will start what? Entering into what? It will enter into this pocket. So it will make a pocket like this in between these two, a pocket there. So blood will be accumulating here. The blood that is supposed to go to the abdomen or go to the legs and all those stuff, it is piling up here to become big and cause what? Issues. Yes, and cause issues. So when it starts tearing, this is a big emergency. Can we leave this hole like this for the next 24 hours? No. Patient will bleed here and die. This is a serious medical emergency, okay, or surgical emergency. So we need to go in and repair this aorta. Okay, we need to go in and repair, suture it back. We suture it back. Okay, yes, to close this hole. There are some patients after suturing, they will come back to the ward and whatever happened, whoever knows, the sutures will remove depending on the pressure in the blood. Okay, so you meet patients that will has aortic dissection repair. Okay, aortic dissection repair, but they came back and what? And the repair, the thread removed. Even clothes that we use machine to repair the clothes, sometimes the thread remove. So in human beings too, the same thing. The suture can remove. Okay, it can tear, and you still bleed again. So we have to take you back to repair it again. Simple. So it can occur in the chest, and it can occur in the abdomen. The difference is that it occurs in the chest and you start bleeding here. The patient will be having signs of what? Tearing. I've told you, muscle is torn. A tissue is torn, a cell is torn. So if I hold your skin, you hold your skin now and start tearing it, pulling it. You will feel that tearing pain, and it is never going to stop till you repair it. Sometimes it triggers what the this phrenic nerve. It triggers the phrenic nerve, and it will be radiating to your shoulder or your back. That is it. So if it's in your chest, tearing pain radiating to the back or the shoulder. If it happens in the abdomen, tearing pain radiating to the back, okay, and sometimes to the shoulder. So aortic dissection. Okay, now so there's tear in the inner aortic wall, allowing blood to enter between the layers of the artery, the media, between the media and the intima. Okay, good. So what are the clues? What are the clues? Nclex will ask you. They will give you all these clues. You should be able to diagnosis. Okay, analysis of clue or clue analysis. Okay, so Nclex will give you sudden tearing pain or sudden severe. They will not use this English, mazima. Sudden severe pain, chest pain radiating to the back. The pain, how do we describe it? Remember, PQRS, they would describe nicely PQRST. Okay, so the provocation, okay, this is the quality, sudden pain, radiation, okay, it is radiating to the back. Okay, you check your blood pressures. Remember, you check your blood pressure. Where does the aorta curve? Does the aorta curve here to the right side of the patient? No, the aorta curve to the left side. Remember, there is a branch here that supplies the hand, the left hand, and there is a branch here that supplies the right hand. So what do you know? As a nurse, I must check the blood pressure of this hand and check the blood pressure of this hand. You will realize that the blood pressure of the right hand will be higher than the blood pressure of the left hand. And if you want to do your mathematics and do the deductions, BP of the right hand minus BP of the left hand, you see what? Left hand, you see a wide gap. A wide gap. Yes. That should tell you that what? Oh, okay, this patient is having what? Then, so unequal arm blood pressure, unequal absent pulses. You check your pulse of the right hand, check the pulse of the left. That should tell you perfusion problem is happening. Okay. Then newly neurological deficits, definitely the brain will suffer. Patient will collapse. Are you waiting for your aortic dissection patient to collapse before you work on him or her? Okay. Which hospital are you working? In the town you are working, are there emergencies? Do we have a helicopter to airlift this patient to the city for emergency repair? Sometimes you watch the patient and they die because there is nothing you can do. Even the ambulance, they have to tell you there is no fuel. So family members should buy fuel before we come. Okay. So these are some of the troubles we see where we are coming from. Okay. Yes, it can happen to you. The fact that it's happening to someone does not mean it cannot happen to you. It can happen to you. Okay. Yes. Then signs of limb or organ ischemia. So mostly some patients will be having what is limb ischemia. Their legs, cold skin, absent pulses. Okay. Yes. And they'll be having this paresthesias, electrolyte imbalance, the extremities. Okay. The spleen will be struggling. So it's not easy. It's not a nice condition at all. So what do you have to do? The nursing priorities. Treat this as a surgical emergency. Activate the rapid response code. Obtain your blood pressures in both arms. Large bore cannula. Gauge 14, 16, 18, 20. Sharp. You cannot get IV because the peripheral IVs are collapsing. Intraosseous. I've told you in emergency, don't go and worry yourself with this thing, no, ultrasound. Ultrasound takes time. Patient will die. Sometimes we take more than 20 minutes or 10 minutes to get IV. But you can see your bone, enter the bone with intraosseous, drill through the bone and get your blood. You provide what? Continuous EKG monitoring. Yes, smoke over fire, sky over green, chocolate in my heart, 5 lead continuous telemetry. Okay, then you do your EKG for diagnosis to know your electrical conduction. Administer your aspirin or analgesics and prescribe anti-impulse therapies. Okay, prepare for CT angiography. Yes. So CT angio will let you know that, oh, okay. No, CT angio, they use the contrast dye to run through all the arteries. So they run through all the arteries, contrast dye, they inject it and they run through all the arteries. So when then you'll be watching it on the screen. So when the contrast dye gets here, you see that the dye will divert here. There is a tear here. Okay, there is a tear here. Quickly, emergency response. Theater, where are you? Let's go. Notify the cardiothoracic or the vascular surgery team immediately. Do not administer anticoagulant or fibrinolytic until digestion has strongly been suspected. Okay, yes. So treatment usually begins with what? A beta blocker. Nice, gentle one, labetalol guys. Okay, they will control your blood pressure. You see that nice guy in the community. Yes. And also your heart rate. Nice. Yes. So sometimes people add some small vasodilators like hydralazine. This one, if blood pressure is too high, okay. Yeah, but most of the times when you give your labetalol, it calms down everything. Okay. So you have type A, type B. Okay. Type A, type D. So the type A is the ascending aorta. Type B is what? The descending aorta. The location is in the chest or the abdomen. So take note of that. Good. Uh, another cardiovascular emergency we can encounter in our practice and in our exam is pulmonary embolism. Pulmonary. So you see, the blood is coming from the heart to the lungs. When we took a scan, CTA, see the CT, the contrast dye has revealed that there is a big clot that is blocking one of the branches going towards going to the left lung. Okay, and you see the clot. This is deep vein thrombosis. Yes. So the same, we treat them the same. These two guys, I mean, they are two brothers. So, so big clot here, CTA will review it. Okay, yes. So a clot usually originating from deep vein thrombosis or deep vein travels to the pulmonary system to block the flow. Okay, so what are the risk factors? There is an acronym for it. Me, I'm not good with acronyms, but I added it because some people are good. If you don't like, that does not mean somebody does not like. So we call it the VECOL. Some say virtual, whatever. If you want to know, so the risk factors that can make somebody get pulmonary embolism and DVT, venous stasis. You are somebody who likes sleeping. You like sleeping, always in bed, always in bed. You don't like walking. Here to here, you will pick car. Here to here, you will pick train. Here to here, okay, car. your blood will not be flowing. And if blood is not flowing, they will clot. So you get what? Venous stasis. Immobility is your problem. You don't like walking. Patients come back from theater. Patients on the ward. Which hospital are you working? Somebody has been on the ward for 1 month. We are not giving the person any low dose heparin. Low dose heparin. Those shots, those small, not the IV one, the shot, the one we inject into the muscles or subcutaneous. Low dose heparin, 5,000 units. Give it to them every morning. Otherwise, they will go home and come back with problems. Okay. There is an unconscious patient every morning. Talk to the doctor. Let them prescribe low dose heparin. They will never form clots. You can sleep at one side for 1 year. You will never form clots. Then recent surgery, people with cancer and clotting disorders, and people with what hormonal therapy. Yes, yes, the girls. Those of you who have been chewing, these oral contraceptives like chewing gum. They have been taking it. It has a higher effect on clotting issues. If you are not careful, sometimes some people will get, yes, they are taking contraceptive. It is a risk factor. Then you get pregnant. Okay. Along the line, you start developing issues. Okay, severe leg pain, severe this pain. You were getting all these clotting issues. Yes. So all this and older and obesity patients and previous thromboembolism. So, what are the findings? How will you know that this patient is having pulmonary embolism? Okay, an emboli. Yes. A question, or the patient can never hide it. They will surely come with sudden dyspnea. This is a big Q. Big Q. Okay. They will be having a pleuritic chest pains. Okay. Tachypnea. Tachycardia, cardiorespiratory, hypoxemia, anxiety. Some of them will be sweating, hemoptysis, coughing out blood. Okay. Some will pass out or they will faint. Some will get severe hypotension. Okay. In serious pulmonary embolism. Why? Because this is an obstructive what? This is not obstructive. Obstructive hypotension. Okay. Then unilateral leg swelling in the DVT guys. Okay. The DVT. I'm treating both at the same time. They are all they are all treated at the same time. What is your priority here? If you detect this, if you look at your NCLEX results and you don't pass, okay, they say Q. You should be able to analyze Q, and you should be able to what's the other one? Q analysis and Q. I've forgotten prioritize your hypothesis. So NCLEX will surely test you on these three areas. So by the time you analyze your Q, you should know your diagnosis. A patient will come with this. They will give you plenty signs and symptoms. Okay, you should be able to analyze it and know your diagnosis. Then when you know all these signs and symptoms, which one will you treat first? Prioritize your hypothesis. So A, B, C, D, E. Amasa. Okay. Which one should I go first? If a patient come with coughing out blood, anxiety, hypoxemia, tachycardia, tachypnea, sudden dyspnea, saturation is dropping, which one will I treat first? That is what an hypothesis, what prioritization. Okay, so you support always the airway with oxygen and maintain airway clearance. Place the patient on a cardiac monitor, IV access. Okay, and prepare for CT. So you, if you don't know anything, if you don't know what to do, ask yourself, but I know ABCD. Oh, I know ABCD. So ABCD, what is the nursing intervention for ABCD? Is the airway clear? Okay, let me position the patient sitting up position. Okay, yes, ABCD. I have done that. Airway is cleared. Okay. B, breathing. What is the nursing intervention? Assuming you don't know anything, you're a new nurse, you don't know what to do, but you know that this is what this is pulmonary embolism. What should I do? Breathing. Okay, breathing. Let me give oxygen. Okay, let me give oxygen. Yes, and I mean, if there is a need to give ventilator and all these things, it is not my job as a nurse to give ventilator. It is the job of the respiratory therapist or the anesthetist. Okay, so call them, they will come and give. Okay, call them, they will come and give. Right. Now, see, I don't know anything. I don't know anything. I'm confused. I've never met this emergency before. Everybody is looking at me. What should I do? See, cardiovascular, IV line, sharp. IV is there. I take my blood draws quick. I set up my IV fluid or blood. Okay, I check my vital signs, quick one, and I'm going IV access. So once you do the basics for you, your ABC, once you do it, then okay, let's take the patient to CT because you can't take a patient to CT in this state. A blood vessel has been blocked. A blood vessel has been blocked. We are suspecting pulmonary embolism. You say you are taking patient to CT without IV line. How do we pass contrast? Are we going to give the contrast to the patient to drink? Oh my God. It remembers me of my other some hospital I worked. One nurse was see, it's okay. Yeah. A patient was taking, we were suspecting CT and we took the patient to CT. Okay. Yes. Somebody has given the contrast to the patient to swallow. So that's it. Okay. But nowadays, when you go to CT, there's contract pump into, so they will just connect it to your IV and press, then it will run through all your. So when we run through your IVs, you see that when the contrast get here, you see, something is blocking this artery. Okay, yes. We call it the CT angiography, blood vessel picture taking angiography. Angiography. So we do that. Okay, then they will do the CT perfusion. For normal CT, you can take a patient to a CT scan without IV. That one is for normal CT. Okay, you have come that you are having severe headache. Severe headache. You just walking, you are coming for test. Severe headache. Okay, let's go and do CT and know what is going on in your head. So we go and take we want to know the anatomical structures. So the right hemisphere, left hemisphere, we check the cells, everything is fine. Okay. We check the central circles and all those ones, everything is fine. Cool. Anatomy, we are done. No IV. But when it comes to issue, stroke, okay, pulmonary edema, all these ones, or more, IV line is needed. Okay, good. Then administer anticoagulant as prescribed. Anticoagulant as prescribed. Anticoagulant as, then you prepare for thrombolysis. So sometimes we give the heparin drip. In pulmonary embolism, when a patient comes, okay, before you give your heparin, you should first know the patient's weight. What if the patient is unconscious? You should use the bed weight, the bed the patient is lying on, to measure the weight. Yes. So if you are working in a small hospital that doesn't have plenty beds with weight on, okay, let us take one bed that has a weight to the emergency room. The emergency room. Every ER or ED you go, we have an emergency room that is always ready. Okay, like the theater is always ready for emergencies. So that bed there should have a weight, internal weight. So even if the patient is unconscious, we can still get our weight. Okay, yes. But before you give the drip for heparin, okay, you should what? Give what? The first shot, the shot, the low, the heparin dose, one dose, the first dose, the 5,000 units, one. Okay, you give that one before you come and give the drip. And I've told you already that heparin is going to what? The intrinsic factor. How do you check the clotting time? The time it takes for the blood that is in the intrinsic factor. This is the extrinsic. The blood, the time that it takes for the intrinsic factor to clot, blood to clot. Because you can't go and give this abnormally, this heparin, and go and destroy clotting issues here. Okay, yes. So the time it takes to is to do what your APT or the APTT. Okay, it's the same thing. Okay, this is the partial prothrombin time. Okay, and this is the prothrombin time. So people like the prothrombin, not the partial one. So they do the PT, 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 not the partial. We want the total, the PT, okay, the PT. So heparin, 1, 2, 3, 4, 5, 6, 7, prothrombin time, PT, okay, PT. You check it. Yes. So you do those ones, you check. I'm giving heparin every 4 hours. I should take blood sample to the lab to check for the PT or PTT. Okay. And no, is my blood clotting ability here still okay? When you come and the prothrombin time is so high, the result is so high. Okay, what is the normal PTT? Yes, somebody should shoot. If you know the answer, shoot. When you come and it is so high, it means that in case there is any bleeder, this one and blood is start oozing out here. This one is not going to clot fast. The time it will take to clot has been elongated or prolonged. That is it. So you check it every 4 hours or 6 hourly, 6 hourly PT, 6 hourly PT. What is the PTT? What is the normal PTT? Okay. And with the DVT guys, never hot massage any suspected DVT, which we know. Okay. Acute heart failure and pulmonary edema. Acute heart failure and pulmonary edema. 60 to 80 seconds. Perfect. Yeah, right. So the higher, sometimes above 100, 120. If your results come and it is 120 and above, that is a critical lab result. You should stop the heparin drip. Wait for 1 hour, sometimes 2 hours. Follow your hospital protocols. Okay, follow your hospital protocols. Yes. Let some of the heparin digest and leave the body. Then you continue again. That is it. Okay, so the next emergency medical condition. Hey, 25 to 36. Wow. So, The next emergency that you can meet a cardiovascular is what? Acute heart failure, and pulmonary edema, fluid retention. Okay, so once we are talking about the pulmonary cardiovascular system, fluid can accumulate in the heart. Fluid can accumulate in the heart, and fluid can accumulate what? In the lungs. So let's start. Let's go on. Okay. So this is a normal alveoli. If you look at it, okay. So this is the blood vessel. The red is the blood with the pink. And this is the alveoli. See, okay, the alveoli nicely. Have you seen this small space? This small space, the light pink, small, just above the white one. A small space. Okay. This is the space that if the blood vessel ruptures, or if there is hypertension in this blood vessel, okay, or if there is what? Capillary distraction, let's say infection, the fluid will leave here and accumulate here, and we call it what? Pulmonary edema. Okay, when you do chest x-ray, you will see something like this fluid with a meniscus. Fluid forms a meniscus. Those of you who did physics, if I put a cup and I pour a fluid in it, water, it does something like this. It does not do this. Water does not do straight like this. No. Water forms a bond with the walls of its container. So they form this angle, acute angle. We call it what? A meniscus. This acute angle here, a meniscus. So on your X-ray, you will see the meniscus. So if you see like this, the meniscus. Perfect. I should tell you that there is a fluid sitting in the lungs. Okay, right. In pulmonary edema, see, the fluid is moving to what? And the alveoli, the wall, is very tiny. Okay, yes. So the least thing, it pushes the alveoli up, causes issues. Okay, pulmonary edema. Okay, so you can see it very well here. So you see the water. You see the water. How can oxygen cross this water to this place? So patient will be building carbon dioxide, but the oxygen is not crossing. Okay, in the bloodstream to carbon dioxide will become big. Okay, it will become big. That patient will be having acidosis, respiratory acidosis. Okay, so here you have to what? You see the fluid between the alveolus and the capillaries. Yeah, the fluid blue nicely. Let me make it big so that you appreciate the picture. So you see a lot of fluid, pulmonary edema. If you go and give somebody plenty IV fluid, especially children, the fluid is coming here. They cannot breathe. So you have to drain it with what? Your laces. So this is pulmonary edema. Okay, good. So patient will come with a severe edema, autopnea crackles, hypoxemia, pink frothy sputum. That should tell you that no, trouble has come. Anxiety and restlessness, the standard jugular veins for the heart failures, uh, peripheral edema, and possible hypertension or hypotension. So I'm treating both pulmonary edema and heart failure, fluid accumulation. Okay, good. The priority here Prioritizing hypothesis is what you position the patient in the upright with legs dependent if tolerated. Provide oxygen, okay. Provide oxygen and ventilatory support when needed. Apply continuous cardiac monitoring. IV line is still needed. Administer prescribed diuretics and vasodilators. Monitor your blood pressure, electrolytes, renal function, and urine output, and respond to treatment. Okay, so a sudden decline in blood pressure. This is where the question will come from. A sudden decline in blood pressure, altered consciousness, cool, clammy skin may indicate what? Cardiogenic shock. So they will put the question, they will add the qualifiers, a suddenly. This one, okay. That should tell you that, oh, okay, I'm having this trouble. So let's enter cardiogenic shock. Something is troubling the heart, that the heart wants to give up. Cardiogenic shock. Okay. So when you get a slide, you go through the algorithm. The heart pump cannot pump enough blood to perfuse the organs. So pump failure. Blood is still sitting in the heart. It's not going out. Okay. We do hypertension, low blood pressure. Heart rate is trying its best. It will try. Later, it will give up and so get bradycardia. Weak pulses, cold, clammy skin, confusion, urinary. For cardiogenic shock, I mean, I would choose cardiogenic shock over what? Aortic dissection. Yes. Pulmonary congestion and elevated lactate due to what? Hypoperfusion. Hypoperfusion. If you get lactate is so low, it means that what? I'm not getting enough blood to the cells. So the cells are building what? Lactic acid, causing what? Metabolic acidosis. If you are not lucky and this patient is type 1 diabetes, you start getting what? DKAs. And anion gap will be so wide. A gap will be so wide. Yes. So all these things are the things you should connect. So how do we help this guy with cardiogenic shock? Still your ABCs. So and the A, maintain airway clearance. Okay, position your patient that they can breathe well. Will you keep this patient in the supine position? No. Okay, patient will be in the upright position. Okay, then oxygenation will go for the breathing. Circulation, IV line, reliable. Don't go and do any IV line that you come and give fluid and the hand will become big. Okay, continuous EKG monitoring and blood pressure check. Treat underlying cause such as MI. Administer prescribed vasoactive medications. Okay, to squeeze the blood vessel like your ephedrines, so that blood pressure will shoot up. Okay, yes, the vasopressors and the norepinephrine. So you give all those ones. Prepare for urgent revascularization or mechanical circulatory support. Avoid indiscriminate large fluid boluses when pulmonary congestion is present. You don't even have to wait for pulmonary congestion to be present. Avoid giving blood pressure, plenty blood fluids. Sodium chloride, ringer's lactate. They will shift the fluid to the interstitials and cause edema. Okay, good. So as we are doing cardiogenic shock, let's consider its brother. The other brother of cardiogenic shock is what? Which is also an emergency. is cardiac tamponade. Cardiac tamponade comes with a certain triad. We call it the Beck's triad. Okay, so see cardiac tamponade. We will come to Beck's triad, don't worry. Okay, so cardiac tamponade. If you see the pericardia, so this is the heart. Okay, that's the heart. Okay, and this is the sac around the heart. Okay, we call it the pericardial sac. In between the sac and the heart, okay, there is a fluid here that will make sure that what your the sac and the heart does not rub against each other. It is very slimy, like lubricant. Good. But fluid can shift from the heart muscles inside the heart muscle cells to what? Outside. Those of you who followed me from beginning, not today, anytime you hear the word edema, this word, it means fluid. Majority of the times, fluid has shifted from the cells. It did not go anywhere. It did not come to the blood vessel. It has come here, interstitial space. Interstitial space. So this is the heart muscle. The heart muscle has cells. Inside the cells, they are fluid. Okay. Do you see any blood vessel here? No. So this fluid has shifted, and the only space is what the pericardial sac. Plenty. It will put pressure on the heart and cause obstructive shock. Can the heart contract, expand? No. Okay. Yes, it cannot expand in diastole to get enough blood in the ventricles. Okay. So the little expansion, sometimes no expansion at all. This one can crash your blood pressure and kill you. The heart rate will be trying, but it will get up, fed up, and give up. So patient will be experiencing a certain sign and symptom that if you are not smart, you will never know. If you are not smart, you will never know. That those signs and symptoms, we call it what? The Beck's triad. I don't know who invented this, that they named after a Beck. Okay. Yes. So we have what? The distended neck veins. Why distended? The heart cannot expand. The heart cannot expand. The inferior and the superior vena caves, they are bringing what? They are blood. Here is the case, the heart cannot expand. Something is pushing the heart inside. So what now happens to the blood here? They start building up. Okay, so you start getting signs and symptoms of right heart failure or right ventricular failure. So distended neck vein, that is the first sign. Okay. Next one, the pulses. Okay, decreased pulses. So the pulses, if the heart is supposed to receive 5,000 mils and it only received 500 mils, the blood vessel sitting in your hand or your legs are waiting for 5,000 mils, but only 500 came. Will you get a strong pulse here? No, the pulse is going to be weak and thready or sometimes imperceptible. So weak pulse. Okay, systemic circulation is going to reduce. Okay, that is the second one. Good. The third one, the third one is what? So we have this hypotension, or we call it the muffled sound. Hypertension is just the third one is what? The muffled heart sounds. You see this plenty fluid. Take your stethoscope. and do what? Do your auscultations. You hear sounds. Apartment M, the BTM. You hear sounds, abnormal heart sounds. That will tell you that this is a distant. Why is it a distant? If I can hear the heart muscles in my stethoscope, I should be able to hear through this sound. So you put your stethoscope here, but look at where the heart muscles are. So you see the distance is far away. It's like somebody is standing far away and talking to you. So I'm hearing the heart sound all right too, but it's far away. And in between the heart sound and my stethoscope, I'm hearing water moving like crackles, and you hear the heart sounds far away. So it's a mixture. It has muffled. Okay, we call it what the muffled. So Beck's triad. You can't hide. Okay. Yes. So doctors will go in and drain. Some of them they use syringes to drain, go inside and drain the fluid. Yes, they know where to enter. Sometimes they go through the chest, drain, suck all the fluid out. Okay, suck all the fluid out. Yes. So these are the approaches. They can go parasternal, substernal, but Nclex will not ask you any questions about it. So we don't have to waste our time here. Okay, good. So fluid or blood can accumulate there and cause issues. So hypotension as a result of low this thing and reduced pulse, jugular vein distension, and muffled sounds. You can also see tachycardia, you can't hide narrow pulse pressure. If you check your blood pressure systolic, okay, then the diastolic, yes. No, then you do systolic minus diastolic. You see a wide gap. This is a sign that patient is about to die. Then the pulse is paroxysmos. Okay, paradoxus. Okay, dyspnea, electrical alterations in EKGs and all those stuffs. Then sudden deterioration, GCS will drop, cardiac problems. Okay, yes. Then how do you prioritize? You can't do anything about it. You have done your vital signs. You have positioned your patient. Are you going to give IV fluid? No, you can't give. So you take your IVs, get your bloods to the lab. Okay, the routine ones. You give your oxygen because oxygen is because some hospitals will say wait for the doctor to prescribe. Some will say give. Okay, so depending on your protocol, the you tell the doctor this is what is going on. Surgical team will be what informed. Then they will come and do what we call pericardiocentesis or cardiosynthesis. Okay. Now let's go to arrhythmias or dysrhythmias. We have so many dysrhythmias, but the one that is life-threatening, that if you are not careful, that can kill you within seconds, is the VFib and what? The VTAX. Okay, the VFib and the VTAX. So anytime you see anything like this, ask yourself, is the patient having a pulse? That's the first question. Secondly, is the patient stable or unstable? Okay, signs of instability, the vital signs. Every system, you should know the signs of instability. So hypotension, altered mental status, signs of shock, ischemic chest discomfort, acute heart failure. Every system, respiratory system, GI, you should know signs and symptoms of what? Instability, unstable. Okay. Patient has tachycardia with a pulse. It means if patient is stable, obtain your 12 lead EKG and treat any underlying cause, the HNTs. You treat it, tachycardia, sinus tachycardia. Patient is stable. Okay. Yes. If patient is unstable, some people will even what? Some people will even collapse. Okay. But patient is breathing. Okay, patient is unstable. There is a pulse. There is a pulse. Patient is breathing. You are not supposed to do CPR. You do what we call synchronized cardioversion with lower dose. Okay, always start from the lowest dose. Then, if it fails, you shock and the rhythm does not change. You increase the dose a little. Okay, then you shock again. If it doesn't change, give a higher dose and shock. Mostly on the third attempt, the EKG will start becoming, or you see a normal PK or RST. Okay, not the sinus tachycardia or not the VTAC, sorry, the VTAC, ventricular tachycardia, like this. Okay, yes. Patients, sometimes you get bradycardias. I've told you that bradycardia is not an emergency until patient is not stable. Patients start showing signs of bradycardia, effect of bradycardia. So what are some? Patient has bradycardia. On top of that, he is having hypotension. He is complaining of chest pain. The brain function is dropping, altered mental status. Patient is entering into shock or showing signs of shock. Patient is showing signs of heart failure. It means that the bradycardia is killing the patient. So you must act. What do I have to do? The first attempt is what? Connect the monitors, constant monitoring, observe the EKGs, okay? Do your 12 lead EKG. Medication wise, atropine, atropine. Then the pacing, transcutaneous pacing, okay? You pace the heart, pace it, okay? You pace the heart, okay? Yes. When you pace the heart, when the doctors pace the heart, okay, make sure that you see it on the EKG. Then dopamine or epinephrine to help with blood pressures and all those stuffs. Okay, follow the ACLS protocols for hospitals. If patient gets cardiac arrest, two questions that will come to your mind. Okay, I am seeing rhythms. You can see a patient with this straight line, and you can see a patient with what? Yes. Okay, and you can see a patient with normal PQRS. See all these ones. Okay, so this one, no breathing, no pulse, no breathing, no pulse. This one is breathing with a pulse. Okay, if you see this, this means that the EKG that you put on the patient, the wire has disconnected, so connect it back. Okay, yes, this is an isoelectric line you are seeing. This one means there is an electrical activity there, that it is not, the heart is not contracting. So the atrium is not contracting, the ventricles are not contracting, so you are not seeing the deviations. So this one is cardiac arrest. Okay, cardiac arrest, CA. And this one is no pulse, no breathing. We call it the pulseless electrical activity. I'm seeing electrical activity, but physically, patient is not breathing. Physically, there is no pulse. So we call it pulseless electrical activity. Okay, good. So what are the shockable rhythms? You can't shock rhythms that is not coming from the ventricles. So always ask yourself, where is my ventricle on the EKG? Cool. What is the ventricle doing? The top is the atrium. What is the ventricle doing? Is it running too fast or too slow? Superly slow, abnormally fast. Okay, so uh, you're fast, the ventricular tachys with no pulse, no breathing, CPR, shock. Okay, and we have what? The ventricular fibrillations, you shock. Other than these two guys, any other rhythm, non-shockable, don't shock. Okay, asystole and pulseless electrical activity. Pulseless electrical activity. Patient is, I'm seeing normal EKG, normal EKG. Okay, like this normal cycle, cardiac cycle, but physically, is the patient breathing? Physically, are they having a pulse? No. If no, pulseless electrical activity. This is a fake. Okay, so I should what? Do my CPRs on these guys. Okay, you do your CP, then epinephrine 3 to 5 minutes, 3 to 5 minutes, 3 to 5 minutes. Okay, epinephrine. Never defibrillate. Oh. Okay, now let's look at the causes, the H and the T's, the H and the T's. These are the things that can easily launch you into cardiac arrest if you are not careful. So hypovolemia is number one. That is why anytime we see it in the emergency, everybody will be like, let us correct it. Hypovolemia, blood pressure is dropping. Hypoxia, somebody's saturation is dropping, breathing issues. Okay, hydrogen acids or SS, we call it acidosis. Hypokalemia or hyperkalemia, the H. Then hypotension or poikilothermia. Okay, low. So a woman will be using bleach, will be using steroids, launch into neutropenic. Okay, yes. One day she doesn't have money to buy creams. The body will react. You get what? Steroid issues. Okay, you come to the hospital, your temperature will be superly low. Okay, superly low. The hypothermia. If you don't treat you well, if you see a patient with low temperature, what is the normal body temperature? Yeah, shoot to the answer box. Normal body temperature. Now let's look at the T's. If you know the answer, shoot. The T's, the tension pneumothorax and the cardiac tamponade, the toxins, toxins, oh, yes, pulmonary thrombosis and coronary thrombosis. These are the T's. You look for them, then what? You treat. Another emergency we can see is what? Hypertensive crisis. A lot of people come to the hospital with hypertension. Always group hypertension into two. Thank you. 36 2, 37 2. Okay. So always group your hypertension into two. We have people with hypertension, they are walking normal, they are asymptomatic. My blood pressure is severe. Okay. And we have people with hypertension that they are walking symptomatically. They will come to the hospital symptomatic. Is that how you spell it? Symptomatic. Yes. So you and I, let us bring blood pressure machines, okay, and check. Some will be having very high blood pressure. Yes, that is severe hypertension. But they are not complaining, no headache, nothing. It's only that their blood pressure is what? High. They are not showing any sign of organ failure or organ injury. Okay, the eyes are okay, the brain, no headache, no kidney issues, nothing, but their blood pressure is high. We call them asymptomatic hypertension. So these people, they will come with the crisis, emergency crisis. Yes, they will show you signs of an end organ damage, end organ damage. Okay. How will you know? Somebody has come with high blood pressure. Okay. This is the heart. This is the blood vessel. The blood vessel is connecting to the eye. But the pressure here is superly high that it is destroying the functions of this organ. Okay. This is the main pump, the heart. And this organ, we call it the organ far away from the heart is called end organ, and the blood vessel connect these two people. But Either the heart is pumping superly high or the blood vessels have closed. Okay, somebody is taking drugs, somebody is taking all this. Okay, somebody, yes, blood pressure, whatever the cause, is superly high. Please, the latest statement you made immediately after, I think it's contradictory, so you can clarify. Which statement is that? The non-shockable. Yes. So the non-shockable rhythms are the ACE2 and the PEs. Okay. The ACE2 and the PEs. Okay. Corrected. Right. So the end organ, patient will be showing what? Dizziness, blurred vision. Okay. Patient is having this is my kidneys. Let us connect one blood vessel to between these two brothers. Blood pressure is superly high here. The kidney will be struggling. Because of that, the kidneys will not what? Excrete any urine. Okay. So urine output will drop. Within 1 hour, you get 15 mils per hour. Within 1 hour, patient is drinking and bringing out 10 mils, 18 mils. It means our end organ. Okay, let's go to the brain. Let us connect blood vessel to the brain. Okay, blood pressure here is superly high. The brain will be struggling with encephalopathies, altered mental status. Yes, so all these are possible. Man. There can be stroke, ACS, pulmonary edema, AKI, ADs, and visual disturbances. When you start seeing this, you should know that no trouble is on the way coming. Management requires controlled reduction with IV medication and close monitoring of the blood pressure. Do not decrease blood pressure too rapidly. That's the precaution, unless the emergency you are dealing with requires a specialized target. So is it? I always tell people that you as an individual know your normal blood pressure, know your baseline. Okay, right. So if you are doing blood pressure, then let's look at what this time around. It is not the artery from the heart to the heart. It is not the artery from the heart to the heart. It is an artery from the heart to other part of the body. That something has closed it. We call it acute arterial occlusion. Okay, acute, especially a sickle cell patient, vaso-occlusive crisis, red blood cells can lock here. You sleep and wake up and you're having severe vaso-occlusive crisis. Okay, yes. Patient is not sickle cell. What do? We still have to assess for limb ischemia. So you see how this small boy is crying because it's serious. The 6 piece, we did this 6 piece in what musculoskeletal system, so you should do it. So if an artery from heart to heart will give you chest pain, then the from heart to the legs, from heart to the lungs, from heart to other body parts, when it closes, it will give you pain too. It will give you pallor. You cannot feel a pulse, the electrolyte imbalance. So the nerves here will be having what? Paresthesias, twitching, and all these ones. Okay, paralysis and low temperature. We call it the poikilothermia or perishingly cold, cold, clammy skin, cold extremities. Can this person survive in winter? The winter will be so high that when you come back from work, you have to put your hands under running hot water before you begin to feel sensations. So this is what we call it what? Acute arterial occlusion. Okay. So what do we do? A thrombus, these are some of the things that can block it. A thrombus, an embolus, or even trauma can block that artery. So you need an immediate medical or surgical intervention to remove it. So look at somebody's legs. It's blocked. See this big clot. Yeah. Okay. Good. So somebody is having severe hot manifestations. Look at the bluish discoloration and all this. Capillary refill will drop like something. Okay. Yes. Excruciating pain, color paleness or cyanosis. You see it. Okay. So always arterial blockade, your six piece neurovascular assessment, neurovascular assessment, neurovascular assessment. You are done. If you remember your 6 piece, you know how to treat this guy. You are done. Okay. A pulseless ischemic extremity is what? Emergent, because delayed treatment can cause irreversible tissue death, and we have to do what? Cut this line, a leg off, amputate. Those of you who go and tie tourniquets and forget, you are causing acute arterial occlusion. You are blocking arterial supply to the limb. Okay. Some people would tie blood pressure and forget and leave. Patient is unconscious. They can't talk. Okay. Yes. A patient has been on your ward so many days, no what? Blood thinner. And embolus will close one of the arteries. Okay. So you notify the vascular team. Then you compare the pulses of both limbs and sensation. Never apply heat. Okay. And do not massage the limbs. Keep the extremity in a neutral or slightly dependent position and prepare for anticoagulation or revascularization. Okay. Right. So getting to the close of today. Getting to the close of everything we have done today. Okay. They will say that what critical Nclex priorities. Anytime you get questions like this, okay, you consider your oxygen saturation dropping below 85 before a patient with anxiety, a new chest pain with diaphoresis before a chronic edema patient, sudden tearing pain, you consider it over a patient with what? With unequal pulses before uncomplicated or stable angina. A patient with pulselessness, cold extremity before chronic claudication, chronic pain. Okay. Then unstable tachycardia. Please say is the severe asymptomatic hypertension the same as the urgency hypertension? Yeah, somehow. Okay. Yes. Urgent care is not emergent. It's not emergent. Yes, the indicators are showing abnormal values, but until they have signs of end organ damage, okay, you can call them hypertensive crisis. Okay, yes. So sometimes you'll be in a rush. Patient even drove himself to the hospital. He's not complaining of any pain. He came for slight headache. Okay. You want to by force drop the blood pressure because you faint the patient. Okay. Unstable tachycardia, you give priority to this guy over stable asymptomatic tachy. Somebody is having pink frothy sputum. Okay. You give it what? Priority over what? Peripheral edema. Then hypotension. with jugular vein distension after a cardiac procedure before a routine post-operative pain. So, guys, final cheat sheet. Me, I don't like cheat sheets. I know some of you are very good with chew and puff. Okay, so I added it. Cheat sheet, chest pain, ECG, first 10 minutes, it should be done. Acute coronary syndrome, aspirin. Don't rush to give morphine first. Oh. Aspirin, ECG, all these things. Nitroglycerin, before you give, check if the patient is having what, taking any potency, impotent medications like sildenafil, tadalafil, the AST guys. Okay, yes. And remember the 12 hours, the 24 hours, and the 48 hours rule. Okay, aortic dissection, patient will never lie. They can't even hide tearing pain on equal pulses or blood pressure. Then pulmonary edema, they can't hide. They will have sudden dyspnea with pleuritic chest pain. Okay, pulmonary edema, you need to sit the patient upright. Okay, then oxygen and prescribed diuresis to drain the fluid from the lungs. Tamponade, cardiac tamponade, you get hypotension plus jugular vein with muffled sound. Unstable tachycardia, unstable tachy or ventricular tachycardia. You will synchronize, patient is unstable, synchronize cardioversion. Vein fill and pulseless VTAC defibrillate. PEA and assist CPR epinephrine unshockable. Okay. Acute limb ischemia, the neurovascular assessment and act urgently. Thank you, mom and dads. So this is the end of our presentation today. Tomorrow, I've got questions for you. Tomorrow morning, please. I said that the first person to wake up should call the line so that we all wake up. But nobody called. So today, all of us slept. Please, tomorrow, we are coming to do 50 questions in the morning. Okay, on this topic. 50 solid ones. Yes. So people said it's they want difficult questions. So I've got some serious difficult questions that even if you know the answer is still wrong. Yes. So please, tomorrow come. Okay. Tomorrow come. Okay. Yes. Thank you so much. God bless you. Bye bye for now. Any question? Any question for me? Any question for me? Any question for me? Any question for me? Right. So somebody is asking the time. Ayarega and Olubumi. Me, my end, like 4:30 a.m. We mostly start at 5, yeah, 5 to 7. Okay, it's only 2 hours. It's only 2 hours. Okay, yeah, it's only 2 hours. Which country are you from? The person asking the time. Which country are you from? Let me know your country and I'll get you the time. We will post there. We will post it. So question time tomorrow. Okay. Question time tomorrow. Question time tomorrow. Okay. Question. Please the slide. Yes. I'll give you the slide. Why not? Okay. I'll drop the slide on the WhatsApp page. Please like and share the page. Like, subscribe. Everybody should subscribe. If you are here and you've not subscribed, please. Oh yeah, oh yeah, oh yeah, oh yeah. Subscribe. Please subscribe. Click on the subscription box. Subscribe to the channel. You can't be part of this group without subscribing. So subscribe to the channel. Subscribe to the channel. Okay. Subscribe to the channel. Let me give you the subscription link so that you tap on it before you leave. Subscribe to the channel. Subscribe, please. Subscribe to the channel. Okay. Subscribe to the channel. That's the channel. The channel link. Subscribe. Okay. Subscribe. If you are not part of the WhatsApp group too, this is my. If today is your first time here, I-75. Call me. The slide will yes. So Mr. Virus, I'll put it on the page. Subscribe to the channel. That's the link there. I've posted it. And I've posted my number too. Yes. Subscribe to the channel. Subscribe to the channel. You see, we are doing our best. We've done exactly 2 hours. Okay. 2 hours. So you people should join early. Join early. Don't stay home for long. If you set the time, join early. Okay. Subscribe to the channel. Subscribe. Subscribe and like. Everybody should like whatever we are doing. Hit on the like before you leave. Yes. We are 50. I want to see 50 likes now. Hit on the channel. Hit on the subscription box. Hit on the likes. Yes. Thank you, Jennifer. How are you, Jennifer? Which country are you from, Jennifer? Yes, Jennifer. Appear J. Hit on the channel. Like. Good. Like. 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 I'm good. Which country are you from? Miss Everest. How are you? So please say I joined early. Wow. Yes. Canada. Wow. Come and take me to Canada, okay? Frankie, Canada. Yes, Canada. God bless you, sir, and my colleagues. Stanley, how are you? It's a long time. You don't call me. Stanley. No, I think you called me last week. Yes, you did well. We spoke. Yeah. Stanley, have you subscribed? Jennifer, have you subscribed yet? Frankie, have you subscribed? I'm waiting for you to subscribe. We are 51 now. I want to see 51 likes. So hit on the likes if you haven't. Yes, like. Okay, Jennifer, have you subscribed yet? There's the subscription already. Okay. Joanna, have you subscribed? Joanna, hit on the subscription button. Sharp. This is the link. Hit on it now. It's like this page. Everybody is from Canada. Let me also come to Canada. Oh, yeah. Yes. Hit on the subscription button. Yes. Like it. Like it. Like it. Like it. Like it. Like it. Yeah. Like it. Thomas, have you subscribed yet? Have you subscribed and like the page? Miss Everest, have you subscribed yet? Long ago, say and shit. Really? I want to see more Nigerians. Okay, on the page. More Nigerians. Stanley, let me give you that job. More Nigerians on the page. Oh, okay, Tommy. Good. That's good. Yaira Odum. Yaira Odum. Okay, so if you're on the line, I want to know the country you are. Okay. Yes, I just saw your voice note, but I've not read. I'll read it. Sarah, have you subscribed? Right. I'm seeing 50 people now online. So I want to know your country. Please type your country for me. Yes, Zozo, Ghana. Okay. See, Ghana. Victor is Ghana. Yes. I want to see your country. Type your country. I want to see it. Everybody should type. Type your country. Yes. Josephine. Hey. Zozo, yes. Yes, Sarah. Oh, Sarah. You are in Saudi. I came there last week. Oh. I'm lying. Mercy. I want to see your country. Mercy. Mercy, go and look for Lambert before he leaves. Okay. Mary Opoku. I want to see your country. Everybody should type. Country. Country. Really? Olubumi, UK. Nana Abunanya Akun. Nana Abuna, have you answered any question here before? I don't know. It's like your name is new to me. Nana Abuna. Wow. Nana Abuna, have you subscribed yet? Nana Abunanya Akun, have you subscribed yet? Abunanya Akun. Oh, Victor. Jidimafo. Please, I want to know your country. Yes, I've received only 10 people who have shown me their country. Let me know your country. Yes, Everest. Wow. Hey, you're from Nigeria. Oh, I never knew. Mount Everest. Yes. Let me know your country. Let me know your country. Let me know your country. Okay, good. Let me know your country. Okay, good. Okay, so let's do this last exercise, then we leave. Everybody should type any one condition, your highest priority condition that is challenging you. Okay, one condition that is challenging you. I'm writing it now. Let me get my pen and paper. Sharp. Then I do short for you. Only you. Okay. Short course for you. I'm writing. Where's my pen? Short condition. Yes. Good. Please, I want to know your condition. Please write it to. Yes. Oh, EKG, my biggest challenge. Okay. Please. Yes. Yes. Shoot. I want to know your condition. Psychiatry. Just fin. We just finished psychiatry. Okay. I'll write it down. Psychiatry. Yes. 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 I want to know. Yes. Okay. Yes. ECG psychiatry. Maternity. Okay. ECG gives me nightmares. Okay. ECG. Pfizer. ECG. Pfizer, which condition do you want to learn? That you wish you knew. You know. Okay. Yes. So far, I've got three areas: psychiatry, ECG, and maternity. Okay. I want to know. Let me know your condition. Your condition and pharmacology. Okay. Pharmacology, maternal health, and ABG analysis. Okay. Yes. Pharmacology. Yes. I want to know. I want to know. Please type. Oh, if you are quiet, I always say this. If you are quiet, we are not doing Zoom that you talk. So if you are tired and you don't want to talk, I'm listening. I'm listening. I'm listening. Oh, yes. Okay. Okay. ECG. ECG. Pharmacology. I'm going to write all these ones down. And I do a crash course for you. Okay. ECG. Pharmacology. ECG. Pharmacology. ECG. Maternity. Wow. ECG. Okay. Right. Uh, right. Okay. So, yes. I've told you nowadays that we are going according to the plan now. Okay. The curriculum. And all of them are in. So trust me, you're gonna make it. Right. Let's do this exercise last. I can teach the curriculum from afresh. When Nicholas comes back, I'll leave the ATT for Nicholas and Aaron Olubumi to manage that side. Okay. So they will be organizing classes for you. Then myself and Ayarega, we are holding the main session. So when Nicholas comes back, we are starting afresh. Yesterday I did a planner. Okay. So I have I can teach 3 months, which will be 4 times a year. Okay. Or 4 times we go the cycle 4 times a year. That is going to be a very fast pace. Okay. Then I can also make it 4 months. That is going to be 3 times cycle a year. So if you don't know anything about Nclex, you within 4 months you will be Nclex ready. Okay. Yes. So let me know which one will favor you. Do you want the 4 months? We take our time and do 4 months in a relaxed manner, or you want the 3 months crash course? We finish quick, quick, quick. You write and you go. Which one do you want? So if you want the 4 months, write number four. Four. If you want the 3 months, write number three. Okay, let me know your answers. Yes. If you want 4 months, if you want 3 months, let me know. If you want 4 months, write four. If you want 3 months, write three. Okay, this will be the main page. I've also finished drafting the crash course page. Crash course is only 1 month, 1 month preparation for crash course to finish everything. So let me know. Let me know. Please don't look at somebody's answer and write yours. You know yourself. Let me know. Let me know. 4 months or 3 months. So the one that will dominate, that is what we are going to go with. If the four people dominate, we are going to go the 4 months. If the three dominate, we are going to go the 3 months. So the crash course people too, I'll give the curriculum to them. Yesterday at the night, by even 2 a.m., I was still awake. I was doing this. I've done it 3 months, I've done 4 months, I've done the crash course 1 month. So if your ATT comes 1 month, you should be ready for Nclex. So 4 months, 3 months, 4 months, 3 months, 4 months. As for the ATT, I'll give the curriculum to this one, Olubumi and Nicholas. So they will also look through and plan with you guys. Okay. Yes, he will look through and plan with you guys. Yes, so I am managing the main page. Myself and Ayariga, we are the admins there. So that is what we want you to know. So please, 3 months, 4 months, 3 months, 4 months, 3 months, 4 months, 3 months, 4 months. Yes, 3 months, 4 months, 3 months. I'm not getting the answer. So 3 months, 4 months. So when you do the 4 months, I'm responding to happy. Happy asked the question. You mean 4 times? No. So the new NCLEX curriculum, which started this April. Okay. Yes. I have it. And looking at the topics, they will definitely not set NCLEX outside their curriculum. It will definitely come from the curriculum. So if you learn everything on the curriculum, you'll be NCLEX ready. So I can teach the curriculum within 3 months and finish it, but it's going to be fast paced. And I can do it within 4 months, but it's going to be relaxed. Which one is okay for you that you want us to go with? Is it 4 months or 3 months? If we do 3 times, it means we can go over the curriculum 4 times within a year. That's 12. Okay. Then, if we go 4 months, we will go through the curriculum 3 times. Yes, we are going to start when Nicholas comes because Nicholas is not around and I'm stepping in for him for the ATT. Yes, that is why I don't want to start afresh. When Nicholas comes, he has traveled. When he comes, okay, yes. So, which one is okay for you? Look at yourself. Than me, when I take the curriculum, I want the slow pace. 4 months. I am ready for NCLEX. I join the Kill Bank. I do my 1 month. I write my NCLEX. I pass and I leave. Yes. So yes, when Nicholas comes, we will start. We will definitely set the month. Then we start. Okay. So when he comes, okay, 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 right, okay. So let me see the thoughts. Okay, cool. So yeah, I'll count so far. 1, 2, 3, 4. I'll count. Okay, and know the best for you. Okay, perfect. So we have 3 months. We have 4 months. Okay, yeah. So whichever way will be okay for you, we move. Okay, guys. And another last thing I want to say, we are done with the class. So if you think you have something to do, you can go. But when we finish class, we sometimes share ideas, help people. Okay. If you want to pass NCLEX, you have to get time for yourself. Okay. Time for your personal studies. Okay. That should be like 60%. And time for other group. I will recommend one group. Okay. I won't recommend two groups. I will recommend only one group. Okay. If you want to be more focused and you want to learn, I'm not saying you should join my group or you should join anybody's group. You know yourself. Join the group that will help you. Okay. Join the group that you will flow with. Don't chase after different groups. You finish this class from here. As we are finishing, somebody is ready to join another group for another class. No, you are confusing yourself. That's 60% your personal time. It should never reduce. You should get time to learn questions. That's 60%. That's 60%. 30% should be your kill bank. 30% should be your theories. Then when you join here, you will get the kill bank and the theory again. So you'll be fully prepared. You'll be fully prepared. But how many hours do you have within a day? You use 3 hours on this platform, you go to another platform and do another 3 hours. You go to another platform and do another 2 hours. What time do you learn for yourself? Okay, listening to people talking alone, that is not enough. You have to also sit down and figure things out yourself, the strategies and the skills for you to learn so that you'll be able to master. You have to drown the Nclex. You have to soak it in water, drown it, have mastery over it. That is when you pass. It's not about moving from group to groups. Me, I've told myself I will never collect money from anyone. I will never. All these things, YouTube does not pay us. Facebook does not pay us. Okay. Yes. We started this group since 2023, 2024. Okay. I have been paying out of my salary. I have been paying Zoom till we stop using Zoom every month. Okay. I have never called any member of this platform that helped me pay Zoom. No. I do it because the way I struggled before I got opportunities. I don't want people to struggle like that. That is why I want to make it free so that you too you will enjoy. The first person to lead the journey, to make the journey, will struggle. But me, I have this mentality that if I struggle to open a door, I will open it in such a way that those who come before after me will find it easy to walk through that door. That is me, my mentality from day one. I have classmates on this platform. I have classmates from GSS, classmates from nursing training, class from degree. I have friends on this platform. Yes, I don't hide opportunities. I will show you. I'll tell you the way. Okay, I don't have to charge you. Okay, if you give me $100, $200, how much will I charge? Can you give me $100 every month consistently? You can't. So why would I come and take your money? I won't do that. All I want you to do is come. This group is yours. Take it as your own. Invite people to join. Okay. Another reason why we move from Zoom to YouTube is that YouTube has algorithms that the more you do videos, the more they share for people to know. Okay. So you get a lot of people to listen and benefit from what you are doing. I should have been sleeping by now. Yes, I should have been sleeping. If I don't teach, nobody will do anything to me. Okay. But I said, no, we wake up. I wake up at dawn, 4 a.m. I teach. 5 hours time or 6 hours time. I come again and teach. I finish, I dress and go to work and come back home and teach. So, guys, okay, let us buy into the idea. When in this world, when you are doing things for people free, They think it's not genuine. That is how our mentality has been programmed. Okay. That is how our mentality has been programmed. Human beings wants you to charge them, take money from them. That is where they will be serious and committed. But if you don't take money from them, they think, this one, I will not take it serious. I will not take it serious. Yes. So people join this platform, they were enjoying, but they still went to pay money to people. But it's not the same thing. Tell me, those things you go and pay, those monies you go and pay, it's not the same thing they are teaching here. Me, I've even confronted somebody before because whatever we were doing here, that person was taking our materials to charge people and use on her platform. So I confronted her. I can show you messages, and yes, I've confronted somebody about last month. I confronted one admin that whatever we are doing here, she takes our documents and use it on her paid platform and charging people. so so easy. Yeah. So guys, me, I'm not forcing you. I'm not forcing you. But the choice is yours. Okay. When I pray to God, I pray to God that God make me the solution to people's problems. So the people God wants me to be a solution to them, He will surely bring them to me. That is my prayer. Make me the solution to people's problems. Okay. So let us be transformed. Bible says, be transformed by the renewal of your mind. Don't see, I'm not here to take your money. I am not here to take your money. I am not here to charge you. I am here to make you a better person. That is it. Okay. I'm here to make you a better person. So please let us stay and let us be together and fight this cause together. Okay. I trust you. I know you will make it. I believe you. Nclex is not difficult. I know you will make it. Okay. Okay. Right. Thank you. Bye bye for now. Let me give you love emojis. So tomorrow morning, prepare yourself for quiz. Yes, come and solve quiz. So I'll pose the questions, then you answer, then we explain the rationale. 2 hours, 2 hours, 50 questions on this same platform. If you have not subscribed to the channel, subscribe and let us grow together. So 50 questions, scenario critical questions on what? Cardiovascular emergencies. So be ready for it. Thank you. Bye bye.